right, folks, let's break this down together. So we've got a 65-year-old gentleman here with hypertension, diabetes, and now the classic signs of heart failure. He's short of breath, tired, and his BNP is up. Ding, ding, ding. That's our big clue right there, isn't it? BNP is basically screaming, hey, this heart isn't pumping like it should. Poor guy, right? But don't worry, we're here to help him out. Now, what do we know? His ejection fraction is down to 35%, which means we're dealing with heart failure with reduced ejection fraction, or HFrEF. And here's where we step in like the heart failure heroes we are. The question is, what's the best thing we can do for this guy to help him feel better and live longer? Let's look at the choices. Amlodipine? Sure, it'll bring his blood pressure down a bit, but in HFrEF, it's like bringing a water pistol to a fire doesn't quite do the job we need it to do. Diltiazem? Another smooth talker. But in this case, calcium channel blockers don't really play well with heart failure. Hydrochlorothiazide, a nice little diuretic to help with the blood pressure, but let's be honest, it's not the superhero we need right now. Carvedilol though, now we're talking. This one's wearing a cape. It's a beta blocker with alpha blocking powers too, so it's like the double agent of heart failure treatment. It helps the heart pump more efficiently, and bonus points, it's actually proven to reduce hospitalizations and improve survival in patients like our guy here. Now, I know what you're thinking, but Dr. Bosnek, beta blockers slow the heart down. This guy's already feeling weak, and you're absolutely right. But here's the magic. In heart failure, beta blockers like carvedilol give the heart a break from working so hard. They let it rest and recover, like putting your heart on a mini vacation. Sounds pretty good, right? So the takeaway here is simple. When you see reduced ejection fraction and symptoms of heart failure, your brain should immediately light up with ACE inhibitor, check, beta blocker, check. These two together are the dream team for improving this guy's quality of life and keeping him out of the hospital. It's not just about keeping his blood pressure in check. It's about making sure he can keep living his life with less fatigue, fewer symptoms, and more years to enjoy. So, the correct answer here, friends, is B, carvedilol. Trust me, that's the hero our patient needs. All right, friends, let's focus second question. We've got a 58-year-old woman with atrial fibrillation, and she's on warfarin, a tried and true anticoagulant. She's also managing her blood pressure with amlodipine. So far, so good. But here's where things get interesting. Her INR is only 1.4 today. Cue the dramatic music, right? Now, for those of you just tuning in, INR is the key to managing patients on warfarin. We need that INR in the sweet spot between 2.0 and 3.0 for atrial fibrillation to prevent stroke. But 1.4, that's like driving on a highway in a convertible without a seatbelt. Not safe at all. So what happened here? Our patient missed a few doses last week. And this brings us to the million-dollar question. What do we do next? Let's break it down choice by choice. A, increase her warfarin dose today. Sounds tempting, right? But hold on. Warfarin is a sneaky medication. It can take a few days to fully reflect dose changes in the INR. So if we go upping the dose immediately, we risk overshooting and suddenly turning her INR into a dangerous 4 or 5. We don't want her to go from underprotected to over-anticoagulated in a flash. B, add aspirin. Aspirin, our go-to for some cases, but not here. Adding aspirin to warfarin in atrial fibrillation? Nope. We'd be adding bleeding risk without getting her INR back in range. Strike 2. C, restart her warfarin at the same dose and recheck the INR in a week. Ding, ding, ding. Now this is sounding good. She missed doses, so her INR dropped. By restarting her usual dose and giving her a week to stabilize, we are allowing the warfarin to build back up to its effective level without messing around with doses too quickly. Plus, we'll recheck that Indian rupee just to make sure it's back on track. D. Discontinue warfarin and switch to rivaroxaban, not so fast. While rivaroxaban is a solid choice for anticoagulation, there's no reason to jump ship yet. Warfarin is working for her. She just needs a little INR course correction. Switching now would be like buying a new car because you ran out of gas. Let's fix the current problem first. So, what's the takeaway here? Patience, young Padawan, warfarin management is like tending a delicate garden. You need time and precision. Increasing her dose too quickly could cause more harm than good. Instead, we let the missed doses catch up by restarting the usual dose and rechecking her INR in a week. That way, we stay in control without any surprises. The correct answer is C. Restart her warfarin at the same dose and recheck in a week. Easy, breezy, and keeps us from overcorrecting. Alright team, let's roll up our sleeves for this one. We've got a 45-year-old gentleman who's been fighting the good fight against type 2 diabetes for 6 months. He's doing all the right things, taking metformin like a champ and making those lifestyle changes. But guess what? His A1C is still hanging around 8.5%, giving us that side eye like, you can do better. So, what do? How do we get that A1C back in check and help this guy stay on top of his diabetes? Let's look at the options. A. Add glipizide. A sulfonylurea like glipizide could definitely lower his blood sugar, but wait for it, glipizide also increases the risk of hypoglycemia and weight gain. And given our guy's BMI is already 32, do we really want to add more weight to the equation? Nope. Strike one. B. Add sitagliptin. This DPP-4 inhibitor is a solid choice. But you know what? It's not exactly the most powerful when it comes to lowering A1C. And it doesn't offer any extra benefits beyond just controlling blood sugar. So, we can do better. C. Add empagliflozin. Now we're talking. This SGLT2 inhibitor is a double hitter. Not only does it lower blood sugar effectively, but it also promotes weight loss. Yes, please. And even though our guy doesn't have a history of cardiovascular disease, if he ever did, we'd be doing him a favor because SGLT2 inhibitors have heart protective benefits. This option is looking pretty sweet right now. D. Increase metformin dose. Hold on, friends. He's already on the maximum dose of metformin at 1000 milligrams twice daily, so that ship has sailed. Increasing it further won't help. Time to call in some backup. Now, if you're thinking like a true detective, you'll realize that empagliflozin is our guy's best bet here. It's like we're giving him a tool that does double duty, lower his A1C and help him lose weight. It's like hitting two birds with one stone, except, we're saving birds here. Or people in this case. You get what I mean. Plus, here's the thing. Empagliflozin is part of a newer class of meds that's all about targeted treatment. We're not just throwing drugs at the patient and hoping for the best. We're making smart, informed choices that tackle multiple issues at once: diabetes, weight management, and even long-term cardiovascular protection if needed. So, let's get to the final verdict here. The correct answer is C. Add empagliflozin. This will give our patient a better chance at controlling his blood sugar and might help him shed a few pounds, which we all know is no easy task. And here's the kicker. SGLT2 inhibitors are becoming a game changer in diabetes management, so it's definitely worth knowing your way around them. You're not just lowering blood sugar anymore, you're impacting the patient's future health in ways we didn't think possible a few years ago. Remember, being a great pharmacist isn't just about knowing which medication lowers blood sugar the fastest. It's about understanding the whole patient, their lifestyle, their risks, and how we can give them the best chance at a healthier life. And that's exactly what we are doing with empagliflozin here. So go ahead, add that to your clinical toolkit, and next time you see a patient like this, you'll know exactly what to do. Okay, ladies and gentlemen, today is enough. See you next. Until that time, please share your ideas and follow my channel. Bye-bye.